Good morning. I'm George Daley. I'm the Dean of Harvard Medical School, and thank you for joining us today for our second public briefing of the Massachusetts Consortium on Pathogen Readiness, or MassCPR as we call it. MassCPR encompasses hundreds of clinicians and scientists from 15 Massachusetts universities, medical schools, research institutes, and teaching hospitals, working in concert with colleagues from the Guangzhou Institute for Respiratory Health in China, and a growing number of collaborators from Italy, India, and beyond. We're united in our common goal to leverage our collective biomedical expertise to confront the immediate challenges of the COVID-19 pandemic, but we are also committed to building a scientific community that is better prepared for the next emerging pathogen. Now, in the initial wave of the pandemic, as contagion was spreading across the world, governments mandated lockdowns that thwarted the transmission of the virus, but wreaked enormous economic devastation. Now, with communities reopening and coronavirus cases in the US on the rise in many regions, our theme for today's public briefing centers on the challenges of safeguarding public health while re-engaging the economy. Today's speakers will discuss the challenges of preventing a resurgence of disease after the ending of these lockdowns. I'll introduce each of the speakers right now, and starting with Carolyn Buckee, who will give us some post-opening intel on how the virus is moving across communities and how we can use these data to precision target our response. Joia Mukherjee will then discuss the role of contact tracing in disease containment. Ed Nardell will discuss our evolving understanding of how the virus is spread and how we can use this knowledge in our containment efforts. Peter Sorger will discuss the role of protective equipment, PPE, personal protective equipment, after which we will have three speakers who will update us on the state of testing. Howard Heller will provide a primer on testing, including the accuracy of various tests and policy and regulatory responses. Pardis Sabeti will discuss the role of diagnostic viral tests in reopening strategies and disease surveillance, while Mina will then highlight the role of antibody testing in reopening strategies and disease surveillance. We will then hear from Jennifer Griffin from the Massachusetts Life Sciences Center, which has generously funded 9 research projects as part of MassCPR. And we'll hear from 2 colleagues from partner organizations who have helped to form the Massachusetts Testing, Tracing, and Supported Isolation, or MATSI group. And then finally, at the end, we'll have time for you to ask questions of our speakers and the leadership of the MassCPR. We'll be joined by Bruce Walker and Arlene Sharp, who are faculty leaders in MassCPR, as well as all of the faculty co-leads of our working groups. So thank you again for joining us this morning, and let's get our discussion started with Carolyn Buckee.
Thank you. Yeah, I should caveat this by saying that almost everything that I'm going to show is either a preprint or unpublished. So take that, as it comes. All right, so first slide. And actually today what I'm going to talk about primarily is a lot of the work that we've been doing monitoring social distancing behavior in the population using mobile phone data. My group at Harvard has been using this kind of data for a long time in the context of epidemics. And so when COVID-19 hit, we immediately pivoted to try to keep decision makers up to date with what was going on in their local populations. Next slide. So we formed this mobility data network together with Sachin Balsari and Andrew Schroeder. Sachin's at Harvard as well. Andrew Schroeder is at Direct Relief. And my PhD student, Nishant Kishore, has made many of these slides So we are a group of about 60 researchers internationally. Each person institutionally has a DUA with a bunch of different data providers, people like Facebook, mobile operators, camera systems. These are all mobile phone data providers. So they give us information about where people are and how they're moving around. The way we've structured our network is that we have one-to-one connections between each researcher in the network and a particular local, state, or international policymaker to help them guide the response and to provide kind of iterations that are specific and tailored to what they need to know in their local community. And then we work together as a team to kind of figure out standardized analyses. Interpreting this kind of data is not trivial, and it's very nuanced. And so you may have seen dashboards on the internet about how people are moving around. It's actually very hard to interpret this data sometimes, particularly in the context of epidemiology. However, it does provide real-time intel about how populations are behaving. And in that sense, it's a good indicator of current transmission, since the epidemiological indicators we have to keep track of the epidemic are often lagged. So they may be testing, which is of course and has an issue with capacity and timeliness, and then hospitalizations and deaths, which are lagged indicators with respect to the epidemic itself. Next slide. So this data, here's an example from 2 counties, or 2 states rather, with each of these gray lines showing the change in movement patterns for different counties in the states. And you can see along the x-axis for each of these states when these different school closures, state of emergencies, and so on were put in place. And what I want to highlight is that we've seen very different behavioral responses around the country to the lockdowns themselves in terms of how much mobility has been reduced and how that's changed over time, as well as how it's coming back up as we reopen. Now, some of that is going to be the natural behavioral response depending on whether you have experienced a lot of COVID in your community or not. But it's also related to the geographic structure of different places. So of course, New York City, a change of 20% mobility may be very different than somewhere in Arkansas. So we've been working to try to understand these patterns over time in relation to the policies that are being put in place. Next slide. So one of the, because testing is quite challenging, and so confirmed cases may not truly represent the epidemic. We've been working with Nick Menzies at Harvard, who uses death data to model the incident infections that led to those deaths in each county around the country. And so this is called a nowcasting approach, and the paper that it's based on is put here. So essentially you fit the deaths and then you model the outcome and you back calculate how many infections must have happened in that community to cause the certain trajectory of the deaths. Next slide. And what that allows us to do is to map the growth rate, which we call here the reproduction number at a particular time. So that's how many new cases are being caused by each incident case. And we map that growth rate over time. So we can see when changes in the growth rate happened. So we can use this modeling approach in combination with the mobility data to try to understand how the social distancing interventions have actually impacted transmission in different communities. So this is just an example from Norfolk County in Massachusetts, and we see a step change function in the growth rate in the middle of March. And then on the right, you can see changing in particular kinds of movement patterns. So the red and the green lines show movement in and out of the county, consistent with commuting, and movement within is shown in blue. So these different mobility metrics tell you different things about how people are behaving in response to interventions. Next slide. And interestingly, when we look at this across all the counties in the US, each dot on these graphs is a county in the US that has had, at the time of the analysis, had at least 200 deaths, so we could fit the model to it. And if you look on the x-axis, we have the estimate just from human mobility in when the step change happened, so when people stopped moving. And on the y-axis, we have when the change in transmission happened that we measure from epidemiology. So completely different way of estimating this. And they all converge to a massive change of transmission and behavior around the middle of March, around March 15th or 16th. And that's extraordinarily consistent. And so we think that these data do tell us something meaningful about transmission. Next slide. So if we look at Boston, these are areas around Boston that you can see. And what we've seen in cities is that there's a lot of microheterogeneity. There's a lot of difference between different parts of the city, even within a county. So if you progress the slide once. So those red, these are downtown areas and commercial districts. They showed a lot of change in how many people were visiting those places over time. If you move the forward again, slide again. And here are the residential zones. So what we've seen is we've seen an emptying out of residential zones and very little change actually in the neighborhoods where people live. And that makes sense, but again, it means that we can start to monitor some of the small spatial scale patterns that are happening. Next slide. And in fact, when we look among pregnant women and we measure antibodies and look for seroprevalence, we see a very strong relationship between commuting patterns and transmission. Next slide. So here's the correlation between the decline in commuting movements, those in and out movements, and the prevalence in these different neighborhoods of New York. And we think that's consistent with the fact that some of these neighborhoods are simply unable to social distance. They were essential workers and they continued to commute throughout the time, and that's where transmission happened. So we think that this really is a good indicator. Next slide. This is my last slide. So I just want to point out that what we've seen all over the US in cities is that there's been an emptying out. And so there's a couple of cities, and what we're looking at is the percentage change in residency in these places. And you see places like Atlanta and Boston have seen a dramatic decline in people living there over the course of the epidemic. So as we reopen and people come back to the cities, we may see changing dynamics and shifting microepidemiological patterns. Last slide. So within New York, for example, all of that change is actually driven by changes in Manhattan and an emptying out in these parts of the city. So I will end there and pass it on to Joia Mukherjee.
Great, thank you so much. And thank you to the Massachusetts CPR for having me today to talk about contact tracing. Starting my timer. Next slide. So I work not only at Harvard Medical School as an associate professor, but I'm the chief medical officer of Partners in Health. And many of you know that Partners in Health was asked by Governor Baker to help stand up a large army of contact tracers to support the Department of Public Health with the question, is it possible to get to zero, and could we apply lessons from global health to that? And the lessons that we've learned are that all epidemics are largely extremely local, and that without testing, case investigation, contact tracing, and supportive isolation, it's not possible to reopen. And we've seen this in Ebola, particularly in West Africa, and we believe we're going to see it here, as Dr. Buckee has outlined. And also that stigma decreases as testing and care is available. And I think we're seeing this more and more as testing is more available in Massachusetts. Next slide. So here is some data unpublished yet from Rwanda, looking at the first month of COVID-19. From the first cases, 2 cases that were identified in the country on March 14th to April 15th, there were only 135 cases of COVID. And that is because robust contact tracing and supported isolation was done. And there were 14,000 people under active surveillance, 350 in strict quarantine, and 2,200 in a low-risk self-isolation. And so this is the kind of control that can be done if you have contact tracing. And this is in the face of having enough testing to run a 5 to 10% positive prevalence among those tested. Next slide. So at Partners in Health in February, we were preparing with the sites that we work in around the world, 11 different countries, to expand testing, to do contact tracing, supported isolation, and this support I will highlight a bit. Next slide. And then we were asked by the governor, how might we do this in the state of Massachusetts? So first of all, to highlight that all departments of public health across the country are doing their level best to do contact tracing. Unfortunately, during the surge in COVID, they are outmatched by the tsunami of cases. And so our first effort was to really increase the number of contact tracers. So the case investigation were largely done by the Department of Public Health, and then that information went to Partners in Health contact tracers and to the continued work of the contact tracers within local boards of health. The third thing, however, that we added that we think is critically important is the notion of care resource coordinators, which is for the people who cannot quarantine or isolate, who do not have the material resources, money, food, housing, transportation, that we would connect them with resources. And we found this as a lesson around the world. In this period between April 10th and June 13th, we were able to, with local boards of health, contact 126,000 cases and contacts, and we're able to reach 90% of the contacts that were named. Next slide. I just want to highlight this function of social support. Again, we found this around the world, and we're particularly worried about how this will play out in poorer states in the United States as well as around the world. That in Massachusetts, at least 15% of residents who are cases or contacts were in need of some social support. And we've seen this. This is a map of Dorchester, and you see that the most heavily hit zip codes, communities, are those that are the poorest, the marginalized, people who have historically suffered from redlining. We saw a very excellent set of articles in the Boston Globe in about 2 years ago showing the average wealth of white versus Black families in Boston was the difference of $250,000 US to $8. That's $8, not 8,000, not 80,000. And that in that difference lies the spread of infection. And so we've also seen this in Navajo, where we work, where 30% of people in 2020 do not have access to running water. And these are really implications of centuries of structural violence. So my work as a professor at Harvard is within the Department of Global Health and Social Medicine and the Division of Global Health Equity, where we are studying the interactions between these social determinants and health, and then how do we mitigate these strategies. So that's something unique that we brought to the state of Massachusetts. Next slide. So this is my last slide, but in summary, because of this work in Massachusetts, Massachusetts has the only full-scale statewide contact tracing effort. Many states are far, far behind. There are many states that are refusing to test certain groups, immigrants, migrant workers, even in some places, people that summer or winter in a place like Florida who are called snowbirds. They're not considered Floridians. And so the data is very complex. And what we have seen since our work in Mass is that we were invited by many states and cities to support their efforts. And so we were awarded a grant by the Audacious Group to help cities and states all over the country. We're now supporting Newark, the state of North Carolina, the Immokalee farm workers, the state of Illinois, Ohio, and really trying to help stand up this kind of work. So these are sort of the recommendations that we're making based on emerging best practices that we have to have for reopening. Active testing and surveillance for high-risk groups, and continued contact tracing. That symptom screening is probably going to be the best we can do at scale until there are more rapid antigen tests available, and that targeted testing has to be in locations that we expect to have the greatest prevalence based on these social factors. And then once the testing is done, that we need continued contact tracing, continued supported isolation. So I'll stop there. Thank you very much. And I want to turn it over to my colleague, Ed Nardell.
Thank you, Joia. Waiting for my slides to appear. Okay, next slide, please. Somehow I've started with the summary and not the first slide. Could we have the first slide, please? Can you go back to the first slide, please? Thank you. So in our initial experience with this epidemic, we were told by the WHO that this respiratory virus was more or less exclusively transmitted by direct contact by large respiratory droplets. And there's no doubt that that is an important mode, perhaps the most important mode of transmission. But we really discounted the potential for airborne spread. Now, what I have here depicted are the differences between large and small respiratory droplets, and indeed it's a spectrum. It's not black and white, one totally different than the other. But large respiratory droplets that are generated within a relatively small range of the source and settle down. So hence, normally we think of them as settling down within a meter or so of their source. And for good measure, we've insisted on a 6-foot distance between people. But we've also learned that it depends on the wind currents or the air currents in a room, and also the force of expulsion with a cough or a sneeze, and that evaporation rates of particles from large to small also depend on ambient humidity. Now, most respiratory infections seem to be spread by large respiratory droplets, and to some degree a component of smaller respiratory droplets. And as you know, early on in the epidemic, although not from the beginning, there was a call for face masks or covering to reduce spread from the source. And indeed, those are likely to stop both large and small respiratory droplets to some degree. Now, on the right-hand side of the slide, you see droplet nuclei. And these are the very small particles that evaporate from larger ones and remain suspended, and they follow air patterns. So some infections are predominantly airborne, like tuberculosis and measles, and different precautions, particularly air disinfection, are relevant for those infections. Now, close relatives of coronavirus 2, our COVID-19 virus, are SARS and MERS, and those have been shown to have an airborne component. So we tend to think that there is some here as well. Next slide. So there is circumstantial evidence. If large respiratory droplets have virus, small ones must have also, and they've been detected. I mentioned that similar coronaviruses have the virus, and there have been examples of spread in the Washington State Choir example. There is another apartment building in Hong Kong where spread between floors has been indicated, and there's a Wuhan restaurant where transmission from table to table was presumably accelerated or made possible by airflow from an air conditioner. And then recently a paper suggests that the impact of interventions, the impact of wearing face coverings suggests that indeed airborne spread is occurring. So next slide. So here's some interesting data which looks at the cooling days on the bottom axis last year to compare to this year, which are usually similar, and the increase or decrease in COVID. And you'll see that on the far right, that the states that are in June that are already using a lot of air conditioning because of high temperatures are also the places where there's been greater increases in spread of COVID-19, suggesting more time indoors as temperatures rise. And the same, of course, happens in wintertime when there's more time indoors. But the very hottest places are suggesting an increase. Next slide. So this is occurring around the world as well. And if you look at the right-hand side, you'll see the sales of air conditioners in India from 2010 to 2015. And I'm sure it continues, if not as much, then more. And many of these air conditioners are so-called split systems where there's no outside air brought in. And even air conditioners that are not split systems bring very little outdoor air in. So basically, people go into conditions where there is no ventilation. Next slide shows what happens in that. Next slide, please. Yes, that's it. So in an office occupied by 5 people, and this is a subject of an editorial published in Indoor Air this year, basically, as a window is closed and the air conditioner is turned on, the CO2 levels rise steeply and show no sign of turning off within within an hour. And these are suggesting a rebreathed air fraction goes up dramatically. That is, we're breathing each other's air more and more as outdoor ventilation declines. So, you know, as people go indoors in hot weather, the rebreathed air fraction goes up. The risk of infection is quite dramatic. This was written with regard to tuberculosis, but it applies equally well to any infection with an airborne potential. Next slide. So there are only a few ways to deal with increasing ventilation. Natural ventilation outdoors, we know, has been said to be much less risk for COVID transmission. I think that's true. Mechanical ventilation, but at least in many commercial settings, there are limits to how much air you can do. In hospitals, it's quite different, but in indoor spaces, mechanical ventilation is limited. There are room air cleaners like the one depicted on the left, and they have their limits in terms of flow. And on the bottom, you see a germicidal lamp, which we use in tuberculosis quite a bit. And these actually have been shown to produce very high rates of air disinfection compared to ventilation. Next slide. So this was actually a measles epidemic that was blunted in the 1930s or 40s actually in Philadelphia or outside of Philadelphia using germicidal UV. And you see in two different schools, measles outbreak that year, and in the unirradiated rooms in the upper classes, much less transmission, and in the lower classes where one would expect more transmission, there is actually much less. Next slide. So the way germicidal UV works is that we irradiate the upper room, and body heat and other ways of moving air bring the air up into the upper zone where it's disinfected. This is not new technology. It's been around for almost 100 years. It's widely used for TB and now is being widely used for COVID as well. Next slide. There are data showing that it's much more efficient than either air cleaners or mechanical ventilation. And I won't go through the details of that, but in this one study, about almost 10 times more efficient. Next slide. And where it should be considered in the upcoming resurgence, if we have one, would be obviously in a healthcare setting, but also in public buildings, such as stores, restaurants, banks, and schools. And we need to know where transmission is occurring in order to decide where this should go. For example, in nursing homes, where there's so much high contact between providers and nurses, and patients who are touched with care of all kinds, it may be that air disinfection may have a limited role, whereas in other areas it may be more important. And with that, I'm happy to stop and pass on to Peter Sorger, the next speaker.
Thank you very much. I'm a cancer biologist by training, but over the last 4 months as part of the pandemic, we've been engaged in a different activity I want to tell you about, whose origins lie in the first slide, if you could proceed to it. And that is what we've all read, sorry, the next again slide, excuse me, what we've all read in, I think, the popular press, and what we also know from our colleagues in the front lines and hospitals, and that is that there has been a severe shortage in the availability of personal protective equipment of all types. And this has actually probably promoted the transmission within a hospital setting from patients to physicians, potentially also the opposite, and has had a severe effect on physician morale and the ability to care adequately for patients. So existing CDC and FDA guidance suggests that, for example, a physician should replace her or his mask every single time they have a new patient encounter. And I think, as many of you have read, and this individual is representing here in this picture, is that many physicians have been issued a single piece of protective equipment, even in very large hospital settings in the United States, never mind in rural settings, have been asked to use the same piece of equipment for many days in a row. So the effort that we stood up, shown on the next slide, is a citizen and student-led effort whose members I'll show you in a moment, called the Greater Boston Pandemic Fabrication Team. And what we decided to do was, on a voluntary basis, to bring together the best available engineering talent, to pair that with existing protocols for doing clinical trials, and then to see whether we could innovate in the space of personal protective equipment, and also understand the kinds of issues that we just heard from Ed, having to do with decontamination, reuse, and repair. PPE in the developed world, and particularly in the United States, is almost always disposable. And so there's an enormous volume of waste. It's priced at an extremely low price point, and the reason for the extreme shortages are that we have a very long and fragile supply chain. We had a couple of other goals. We wanted to freely distribute all the knowledge that we had through best practices and open source licensing, so we will allow for no proprietary designs coming out. We've ended up with participants, obviously, from our own community, science and medicine, but also a whole lot of local manufacturers and engaged citizens. And it's been assisted quite a bit in coordinating with Massachusetts state government on this. And then finally, we wanted to publish as much of what we found here, even though it's an unusual topic for us in terms of scientists, because the only way to fight misinformation ultimately is, in our world, is to produce some peer review evidence. So let me just show you a couple of the projects that we did on the next slide. The first one had to do with face shields. So an incredibly simple seeming device, but nonetheless one that's very tightly regulated. So there are dozens of criteria of a face shield which are subject to CDC and ANSI, which is a certification body in the United States with parallels all over the world, because of course these are safety critical devices. N95 masks that you'll have heard a lot about, so-called filtering face piece respirators, which are in extreme short supply. And finally, a more advanced form of safety protection that actually provides both a higher level of protection, but also can be worn by a wider range of individuals. And these are called PAPRs, or purifying air-powered respirators. So let me just show you a little bit what we did in each of these cases. So in the face shield shown in the next step, we came up with an iterative design. And if you look on the internet, you'll have noticed that there are designs like this, hundreds of designs like this popping up all over the world. One of the critical questions for any medical establishment is, how do you take a novel design like this, but one that's not coming through a traditional manufacturer, and actually introduce it into a clinical setting, which you might think of as the last mile of the delivery chain. And sadly, we've been approached by dozens of groups all over the world that have banded together, often local manufacturers, made these products, and they're unable to introduce them into a hospital setting. And so what we did is we used the standard procedure of a clinical test. So we got permission from the Institutional Review Board, and we call these as a so-called Class 1 medical device. We did a 4-day clinical test in the emergency room of a major Boston hospital, the Brigham and Women's Hospital. We then went to fabrication, and within 3 weeks, we were able to manufacture 3,000 of these and distribute them in the hospital, where they remain in use, because one of the unexpected benefits of actually doing an iterative design in a clinical test is you produce a product that's substantially superior to what a physician is normally issued in these settings. So this could now be compressed by anyone using our design. The paper describing this is actually just coming out in Cell Press today, I think. This can now be used to compress for anyone else interested into 2 weeks, a process that in traditional manufacturing is taking closer to 2 to 3 months to produce. So this builds local community resilience, and also we found is extremely important for the morale of the local staff. They actually, while facing one of these surges, noticed that colleagues and their scientific associates were actually involved in this type of effort. So in the next slide, you'll see another example. This is, now what are we going to do with this, I should say. One thing is we're continuing to iterate on the design. We've built a sort of flow chart for people who come to us for advice, printed this, and we're really now partnering this primarily with partners in health to see if we can get delivery into lower resource communities. The next slide will show you Just a little bit about what we've been doing on N95 masks. Here we've been much more active. We've got a new sterilization method that's gotten to an emergency use authorization. About 15% of individuals can't effectively fit a mask. And one of the problems with reuse, which is strongly encouraged at the moment, is that the straps break. So we've actually fabricated a frame that can be made again in a low resource environment and actually improves fit. We've looked at the problem that many individuals, here you see a physician who's wearing tape on her face because the masks are so abrading that after a couple of weeks in intense patient care, you're actually bleeding from your face. And so the question is, can you come up with a way to mitigate that without destroying mask performance? And then finally, again, partnered with the state, we've set up testing apparatus to see if we can evaluate foreign manufactured masks, a good fraction of which are probably counterfeit and fraudulent and poorly performing. And finally, the most ambitious project on the last slide before I credit the people who did this is to see if we can actually build a purifying air-powered respirator from scratch. And the group that did this was a set of students whose normal project is to build advanced spacesuits for NASA out of the Mechanical Engineering and Aeronautics Department at MIT. A PAPR filters air from behind you and then blows it at you after it's gone through a HEPA filter. They partnered actually with Milwaukee, the industrial supplier, figured out that you get an equivalently good HEPA filter from an industrial vacuum you can buy in Home Depot. 3D printed those components, and those are actually going for testing today. And we're hoping actually to first deploy this via Partners in Health. So this design from the students, which took 4 weeks to complete, can be compared with what Ford and 3M are doing on the right here. The design that these students came up with is less than half the weight, and we believe it'll be less than a quarter of the cost. So the final slide says, who was actually, what's actually different here? What is going to happen in terms of impact? I think obviously we've deployed products, we've got a series of publications. I think what interests us the most is the idea that we're totally changing the supply chain at the moment. So we have a global manufacturing supply chain that's very long, very fragile, and we're replacing that instead with a local supply chain that's much more nimble, and in many ways represents the kind of resilience thinking that FEMA brings to other emergencies like hurricanes. So we think that these two types of supply chains should coexist, and that we need some changes in FDA regulations, and also critically in hospital practice to make this stick. So the final slide then is, who actually did this work? And it's really quite remarkable. We certainly had the staffing support from the medical school here. That was all critical. We had a group of clinicians, none of whom were infectious disease docs. We have a pediatrician here and 2 dermatologists who are not otherwise busy. But the most, I think, interesting part of this were the students. So the students self-organized. These are medical students or PhD students at MIT and Harvard. We also have now Johns Hopkins and students at WashU. Completely spontaneously came together. All of them have mechanical engineering or clinical experience, and they drove the entire thing to what I think has been a substantial success and has moved much faster than any of the larger, more bureaucratic efforts. And the second incredible group are citizen engineers. Ordinary citizens came to us and said, how can we help? All of them turn out also to be experts in manufacturing, and they're the people who actually made those face masks and got them out there. So I think it's sort of an interesting story with respect both to the people who did it, the way in which groups can come together, but also the need to bring innovation and to an area which we have long neglected and which substantially impacts our ability to respond to these pandemics. That's it. Thank you very much.
Good morning. I'm going to go ahead and talk about the next section about testing. If you can go on to the first slide. Testing for SARS-CoV-2 became available less than a month after the first cases were described, and since then, hundreds of labs and companies have developed diagnostic tests, which of course is a critical tool for controlling the pandemic. But when testing is called for, especially in the context of reopenings of schools and businesses, it sometimes isn't clear what kind of testing is best. So what I'd like to do is review some of the basics about testing, regulatory issues, and other issues that need to be considered. Then Dr. Sabeti and Dr. Mina will be discussing some of the technical and epidemiologic aspects of the two main categories of testing: viral testing that detects active infection and antibody testing that detects prior infection. Next slide, please. We all know that the number of people diagnosed with COVID-19 may just represent the tip of the iceberg. Early in the epidemic, the focus was on testing patients who were ill and who were suspected of having COVID-19. But as testing became more readily available, we also began testing people who had no symptoms, and we began to see the submerged, the less visible part of the iceberg. Next slide. In this graph, the bars, the brownish bars, are the total number of tests done in the last several months in the United States. The blue line is the percent of those tests that were positive. So we see that as more tests are done, a lower percentage of those tests turn out to be positive. The WHO, the World Health Organization, has advised that precaution restrictions should not be lifted in an area until a positive test rate of 5% or lower is seen for at least 14 days. So the US overall has achieved that rate. But if we move on to the next slide, we see that there's tremendous variability from state to state. And this is in part because of the different prevalence of infection, but also because of really wide variabilities in testing resources in different states. The ones on the right, the states on the right, are the ones that still currently have a positivity rate greater than 5%. Next slide. The FDA regulates lab testing devices, and as of yesterday, this slide was made 2 days ago, but as of yesterday, there were 150 COVID tests authorized by the FDA, 126 molecular tests, 1 antigen test, and 23 antibody tests. I want to review some of the regulatory issues and terminology. Next slide, please. When a lab test is developed, it has to get cleared and approved by the FDA before it can be used for making clinical diagnoses. However, in times of crisis, like we're in now, the FDA issues emergency use authorizations, EUAs, to allow new tests to be used even before they've undergone the standard very rigorous scrutiny. This was done for Zika, for Ebola, other critical situations in the past. Next slide, please. Some tests are developed for lab-based devices that can process high volumes of samples at a time. Point-of-care devices generally test 1 sample at a time, but give a very rapid turnaround time. And there are also home testing kits where the patient collects their own sample at home, mails it into the lab for processing. Each of these different platforms requires their own validation of each of the processes that are involved in that particular platform. Next slide. And because of the crisis situation and the accelerated authorization process, many COVID tests have not undergone the usual intense level of testing and scrutiny. There have been several occasions where the FDA had to backtrack and even revoke some EUAs of test kits that were already out there being used. Next slide. No guideline or policy can really be a one-size-fits-all, but strategies can be developed for specific populations. And what I'd like to do is go through the issues that need to be considered by asking who, what, where, when, and why. Next slide. The first question is, who should be tested? Should we focus on those who are at the highest risk of dying from COVID, such as people with diabetes, residents of nursing homes, those who re-enter schools or workplaces, or should we just have universal testing of everybody? Next slide. There are testing guidelines out there. The CDC has a really good comprehensive document that focuses on specific populations such as nursing home residents. Johns Hopkins has an excellent guideline for college reopenings that includes testing strategies. Next slide. The next question is what to consider is what tests should be done. Viral tests, so-called viral tests, can look for active infection, meaning persons who currently have the virus and potentially can transmit to others. Molecular tests look for the RNA of the virus itself. Antigen tests look for proteins and other components of the virus. When we're looking for evidence of prior infection, then we look to the antibody blood tests that are also called serology tests. Next slide. The next question is where? Where do we want to collect the specimen anatomically? And it makes a big difference. The highest virus levels are in the nasopharynx, the area deep inside the nose. So swabbing that area has been the gold standard for testing. However, getting into the nasopharynx requires special swabs with smaller tips. It requires trained medical personnel. We don't encourage people to do this to themselves. It's more uncomfortable than a standard throat swab. And the person obtaining the swab needs to wear personal protective equipment because the patient can cough or sneeze while it's being collected. Where should patients go to be tested? We've all seen the drive-through clinics. Home testing is available, certainly is more convenient and safer. Next slide. When should people be tested? Should it be done on a regular basis? And if so, how often? Should it be done only when people first return to work? Should it be done every week, every 2 weeks? Different plans have different periods of retesting. Ideally, if you had a test that cost only a few pennies, if it could be done on a saliva sample, if it could be done at home, if it was a very sensitive test, if you gave results within minutes, then, well, everybody could do it every morning after they woke up. But we're nowhere near that yet. And lastly, why? When developing any testing policy, it's really important to understand why the test is being done. Is it being done for surveillance to find out how many people in a particular community have the infection? Is it being done so we can isolate or cohort those people? Is it so that we can do contact tracing? Lots of reasons, but I think it's important to answer that question before embarking on a testing program. And then, of course, there are practical as well as political issues with testing. We all know that the more you test, the more you identify. So testing can indeed be a double-edged sword. If you seek, you will find. If you don't seek, you won't find. Next, I'd like to introduce Pardis Sabeti, who'll be talking about molecular testing.
Thanks so much, Howard, and for that, for the great intro and background on all of that. Makes my job easy to just sort of jump in and actually take a moment in the next slide. I'll actually just take a moment and think about reentry, and specifically, here in Massachusetts, we're thinking about reentry in a college town, city of colleges, and I want to give, and I think across the country, it's what's going to be so important is as we start thinking about schools reopening, and I want to take a moment and use the example of Harvard University. I have been on the outbreak surveillance committee for some time, and in 2016, there's a number of animations here, so you go hit next. We started seeing cases of mumps on sports teams showing up, first parotitis and then mumps on different sports teams. Next, moved into the residential colleges where roommates were becoming infected. Next, into the freshman dining hall where staff who were eating there, that was sort of epidemiological link, were infected. Next, into the health services where several nurses became infected, and presumably other people in contact with them may have as well. Next, to a commencement activity that then later seeded an outbreak in East Boston. Next slide. And as you think about, Boston itself, it's a city of, sorry, that's my son calling in the other. In a little bit, baby, there's about, speaking of children, but there are 110 institutions of higher learning and 60 residential campuses. So, in a way, we think of these institutions, they're incubators where you can have outbreaks spread. And if you kind of animate this slide, you'll see that, we were able to start doing a lot of investigations. Hit next. Apologize for all these animations. You could actually see this moving across campus. Go on to the next slide. Sequencing allows us to really investigate things at high resolution. And so we were working very closely with the Mass Department of Health, as well as the Harvard University Department of Public Health, and the Higher Ed Consortium here in Boston. And it was a terrific collaboration where everyone decided to be very transparent. These universities actually named themselves and worked with us responsibly to understand what's going on. And we could see multiple different strains of mumps circulating in the region. Next. And there was this outbreak in East Boston that was thought to be a completely different outbreak. But as we did genome sequencing, we saw that 3 cases, that the cluster came right off of a cluster of Harvard cases. And then deeper investigation showed that 3 of those individuals were Harvard affiliated and kind of traced back to an event there. And so next slide. And then in those 3 cases, the next slide. When we think about it, with the genomics is why we, are very passionate about genomics, is it tell us a lot. On the left-hand side are transmission links that were identified through traditional epidemiology. And these were hard earned by a terrific Department of Health and terrific health services that working closely with Harvard in particular, because there are many cases detected there. There might have been many cases across the country, but a lot of cases detected at Harvard. We're able to really see a number of transmission links. And when we then overlay the genomic data separately, we looked at it. So on the left is purely the traditional data. On the right is purely the genomic data. We saw as a perfect match. The genomic data perfectly matched the traditional data, which shows that it's very, very accurate traditional approaches, but there are a number of links that would have been missed by traditional epi. And so what this shows is what we know is traditional epi is very, very solid, very, very accurate, but is underpowered, particularly when we start dealing with respiratory infections like this that can move so quickly. Next slide. And so as we think about how to re-enter, and we think about the kinds of things that we at MassCPR are trying to do and everyone's trying to do around the world, we're trying to find ways of detecting cases wherever they occur. Individuals trying to develop point of care tests, to detect COVID anywhere, multiplex tests in hospitals that can identify not just COVID, but differentiate it from flu and RSV and other things circulating, and genome sequencing to be able to identify new threats that we're seeing all the time, and to pick up things like SARS-CoV-2 as fast as it emerges. Then we want to then connect that information in real time, so we're constantly getting a map of where cases are coming up, to engage individuals next, to come to attention, to want to come to that system and get their information linked in, and then next, to empower every actor in the system so that we can work as best as possible. Next slide. At MassCPR, our diagnostic working group has more than 150 clinicians, academics, public sector, diagnostic stakeholders, trying to share information in real time with regular calls and also with collaborations with the Guangzhou Institute in China. Next slide. One of the first things that we did when this outbreak spread was just to make sure that we could get scaling in Greater Boston and across the Commonwealth. Our first focus was on Boston hospitals, supporting them, the front line, where we need to be able to detect symptomatic cases, understand what's going on. And, we were Boston hospitals were some of the first hospitals in the country to have diagnostic testing on site. The Broad Institute transformed its entire genome center to being able to do diagnostic testing. Companies like Ginkgo and Quest came in. We have a biotech hub here and a lot of activity to move things forward. Next slide. As we then were able to kind of hold the line at that point, we could start really focusing on accelerating other diagnostics. And so David Walt and his team are leading the diagnostic accelerator established at the MGH Navy Yard. And they're really generating a lot of evaluation, safety protocols, and SOPs for testing 3 different kinds of tests: molecular tests, to pick up the virus, serological tests to pick up exposure, and antigen-based tests that also can pick up the virus in a different format. They procured a lot of COVID positive and negative samples and are doing evaluations. They've already completed 2 deep evaluations of some technologies and have another 10 planned in the line. Next slide. We also have a samples biobank that's allowing us to take these COVID cases across the country and to across our city and share them with partners who want them. Next slide. And then, really working on point of care tests. Next. This massively multiplexed systems as well. Next. Exposure testing, both in the lab and point of care. Next. Advanced sequencing-based technologies, and next. And also pairing those with data analytics. And we have a number of partnerships through MassCPR and across across the city and state and country, developing all of these different points in the system. Next slide. Yeah, but fundamentally there are challenges ahead. We always, we need the point of care to become faster and to be more and more deployable, higher throughput, better serological testing, and really think about implementation in the clinics and populations and that safe return to work, school, and community life. And for my last slide, next. I just want to flag that as we think about schools returning, as important as it is to make sure we have all of the technologies available to them, we really need to educate them. And so this is just something near and dear to my heart. I've been working with the middle school Sarasota Military Prep Academy in Florida over the last 5 years. We've developed a full pandemic preemption preparedness program, two weeks curriculum that ends with a full school pandemic simulation where we use a mobile app that spreads a virus via Bluetooth that they have to respond to, and they just do terrific work. And we can take this moment of reentry to not just sort of come back, tiptoeing back into communities, but to take it, to reinvigorate curriculum in STEM and to excite people. And the last animation is, and another example of this is just the medical school students here at Harvard Medical School created an entire curriculum as well to help medical schools think about this. This is a moment in time that we can become and rise better than we were before as we reenter. Thank you. And now I want to introduce my colleague, Michael Mina, who will give us a really terrific rundown I've gotten to see. So, Mike.
Thanks very much. So I'm going to be talking about how antibody testing and viral testing can be used both together for surveillance, and then what are some strategies for surveillance. Next slide. So why do we need surveillance? This virus is not going away anytime soon. This is on the left, you see a graph of the US, and unfortunately we're seeing this very disheartening increase in cases recently, which has been discussed much in the media. And the important thing to recognize is right now we're in June, July, August, we're in the summer months. This is a very seasonal virus, and it usually, coronaviruses normally expand during the fall in October and November. And so we're particularly concerned epidemiologically that this virus, that we might just be seeing a little bit of what's to come in the fall. So we have to ensure that our surveillance systems are set up and ready to go come October. Next slide. So there's a few different types of testing that we might use for surveillance. And so you've heard about them. One is virus testing. And this is to look for the here and now. It's what is happening in an individual at that moment when they're infected, if they're infected, so that you can act, you can isolate them, you can contact trace their contacts. Antibody testing is a slightly different approach. It's a little bit delayed, but the benefit is that the signal doesn't go away. Once somebody becomes positive, they usually remain positive for weeks, months, or years. And we can use that to our benefit to actually be able to survey a population when you're trying to survey many, many people over a long period of time and detect outbreaks. Next slide. So this is just an example. On the left here, you can think of each column of these two graphs as 1 week in time and each row as a person. And the whole point of this is just to show at a population level what we might see. So on the left is is sort of presence of virus that would be detected with viral testing. And if you were to be just sort of randomly monitoring a population virus testing, if you measure a community at sort of the wrong time, you might actually find that there are no cases that are detectable at a given period of time. And that could be actually quite distinct from what's actually happening. It's just that the signal tends to drop off after a couple of weeks of somebody being infected. And so you might be missing them. On the other hand, if you use antibody testing, you have about a week delay before the people become positive. But if you take that same group of people and you test them at that same time for antibodies, you would see in this case that there were 10 cases that had happened in the past. 3 of them would have been identified as very recent infections, and you could sort of put on your alerts for an emerging outbreak. So these two tests can act very differently, and both have their place for stopping outbreaks and surveying populations. Next slide. So as one example, if you had a community that was 5% positive based on virus testing, that's important to know, but you really don't know what that means. It's like looking at your window and seeing that there's a storm upon you, but you don't know if the storm is just hitting you or if it's passing, if it's going north or south. You really want some epidemic trajectory information so you can know where to allocate resources. Next slide. And what this is an example of if we took that same community where we have 5% virus positivity, but we also perform serological evaluations. If we found, for example, that 55% of the community had antibodies already existing, evidence of pre-existing, of previous infection, we would probably know that that community is probably on the downswing of an epidemic. On the other hand, if we had 6% seropositivity, antibody test positive, we would want to throw in all the PCR and virus testing we can, allocate resources there to mitigate the emerging outbreak. So these two tests can really work very well together, and antibody testing gives you an understanding of where something has been so you can know where it's going. Next slide. So now I'm going to talk a little bit about some characteristics and trade-offs that could be made for surveillance testing. Next. When I look at surveillance test characteristics, these are kind of three bins that we could that could exist. You can have a test that's very sensitive, very fast turnaround time for results, or very low cost, so you can do it very frequently. You can pick one or two of these, but it's very difficult to get all three of them at once. And so the usual priority order is that people usually want a very sensitive test. You want to know that if somebody's positive, that the test is going to pick it up. You want cost to be low, and you want to have speedy results, but that's oftentimes seen as sort of tertiary. Next. But is this the correct order? A fast test that's sensitive can be very, very expensive for surveillance. But what about a test that gives you very fast results, is inexpensive, but is less sensitive, maybe even 100 times less sensitive in terms of the virus particles it can pick up? Is this important? And next slide. And the reason why this is important is because such tests are available today. We can have fast and inexpensive, but less sensitive tests. But right now there's been an immense focus on the sensitivity. So we wanted to ask the question of, is this necessary or could we do better? Next slide. So the way that we have to look at this is we have to focus on the viral kinetics within an individual. What I'm showing here is from the days since infection, people usually, the virus is growing. And once it starts to become positive on the high sensitivity test over there on the bottom left of that graph, it's usually just a matter of a few hours before it goes from, before the low sensitivity test also becomes positive. And then the virus, and it's only at that point that the virus usually becomes transmissible in the individual. And then you end up seeing sort of a trail off and detection later on actually of non-viable virus. But the important thing here is that the false negatives that we would get from the low sensitivity test is just a very short window of time, that little red bar right there. And so with that in mind, we wanted to ask the question, how important is the sensitivity of the assay within this range? Next slide. And so we modeled this using mathematical models that I won't go into detail on, but on the left, you can see the amount of infectiousness that's removed given the different frequencies of testing and given two different types of tests. One is the high sensitivity test in pink, and the other is the lower sensitivity test in burgundy. And the point of this slide is just to show that at the population level, the differences between these two tests that are 100-fold different in sensitivity is really very little. The most important thing here is how frequently you can actually test the community. And similarly, at the infection rate on the right side, if you can test every day or every 3 days, you can really drive outbreaks to just about zero with both tests. Next slide. And similarly, the last bit is to understand it's not just the sensitivity, it's not just the frequency, it's also how quickly can you get the results out to the individual. And so the 0, 1, and 2 here for each bin is essentially saying if you have the 0 is very rapid results within minutes, 1 is 1 day delay, and 2 is 2 day delay. So this essentially shows that if you have a 1 or a 2 day delay, it can actually really harm your ability to decrease incidence in the community. So generally we want to prioritize here fast results and low cost, high frequency tests, and actually sensitivity, which is usually prioritized first, should be maybe tertiary. Next slide. So just to conclude, this is the usual priority order. And what we're really interested in, I think, is we can start rethinking this and use a more optimal priority order would be cost and then return of result speed. And then way down the line might be the sensitivity of these tests. Next. And I just, Danielle, Larimore, Roy Parker, James Hain, Millen Tommy, and Brian Wilder helped with a lot of the modeling work here.
Thank you, Michael. So let me thank the speakers and also say that please anticipate asking your questions in the Q&A feature. We have several questions already and some have been answered, but at the end of the next section, we'll be taking some of those questions. So please log in. It's now my distinct pleasure to introduce Jennifer Griffin, who is the Vice President of Industry Strategy and Investments at the Massachusetts Life Sciences Center. The Mass Life Sciences Center is an economic development and investment agency. Its mission is supporting the growth and development of the life sciences in the Commonwealth. And Jennifer is going to be joined by two colleagues whom she'll introduce. So let me turn it over to Jennifer.
Thank you, George. And I just want to take a moment to also thank Arlene, Bruce, and David. Really, the MassCPR is so emblematic of what the Massachusetts life sciences ecosystem is capable of, and we couldn't be prouder to be a funder. So thank you for your efforts. In addition to funding the MassCPR, the Massachusetts Life Sciences Center also has funded about $4 million worth of manufacturers who have pivoted to manufacturing PPE at this critical time. And we're also part of an effort called the Massachusetts Testing, Tracing, and Supported Isolation Group, who at this time I'd like to introduce Ben Linville-Engler, who is the director of MIT's System Design and Management Program, as well as Danielle Allen, the professor at Harvard, and the director of the Center of Ethics, to give you a little more insight into what this MATSI group is trying to accomplish at this time.
Great, thank you so much, Jennifer, and to everyone for having us. Actually, all the previous presenters will make our job a little bit easier in explaining what we're doing. If you could go to the next slide, please, Rachel. So as Jennifer mentioned, we are looking at the idea that was kind of introduced by Joia around testing, tracing, and supported isolation, and really taking a systems process view to look at what are the different functional pieces that need to align to actually achieve the outcomes that we're looking for from the public health standpoint. And really important to this is what are all the different trade-offs and risks along the way. Folks mentioned sensitivity in testing or costs, but also supply chain issues that may exist and availability of equipment. But then also looking at what might be some of the friction points that exist between some of these interfaces. And so if you look across here, we're looking at things like kitting and sourcing of materials, whether it's equipment or consumables, things like test swabs or viral transport media. How is sample collection being done? How is it being transported? And maybe what's the accessioning process for logistics? For sample processing, there's a number of different test methods that were just presented, but availability for equipment, whether it's from Hologic or Roche, and the associated consumables for processing testings may be limited. And then how are results communicated and then connected with the contact tracing groups here in Massachusetts? How is environmental disinfection done? And then how is isolation supported? And if you can advance the animation one, please. You'll see here in Massachusetts, the stated target goals are 45,000 tests per day by mid-July, with another 75,000 in total by the end of December. So that's looking at really that sample processing capacity. And if you can advance to the next, thank you very much. We're looking at sort of what are these key system metrics, right, that work across this whole chain as these are all integrated together. Number of tests conducted, test results turnaround time, the positive tests per 100,000 or positivity rate, contact tracing turnaround time, and number of contacts tested. So if you can advance one more, what you'll see is there can be a long delay between the time in which a sample is collected and when it actually works through this whole process. And the person may get the results, and that can be communicated to the contact tracing group to actually begin their work. And we see a critical feedback loop is how do you connect the people who have been in contact with someone who is positive to the sample collection or getting tested so that we can do that in a rapid fashion. And as you saw in the previous presenter, there's a trade-off between sensitivity and timing and cost. And some of what we're looking at, if you could advance the next animation, is really what's on the horizon. And some of the other previous presenters talked about different populations coming back into the Boston area. The Higher Education Working Group has released a reopening plan that exists for a lot of the academic institutions coming back. And what does surveillance testing look like for that? But more importantly, what is the funding opportunities going to be there? Also, as Peter mentioned around PPE, there's a link to the long-term demand for PPE based off of the prevalence of the virus in our communities and how well we can suppress it. And then how do we continue to communicate and outreach to communities that are more impacted, and how can we enable them to actually find their way into this process? So this has been our view in the Massachusetts area. We have convened a large group of different stakeholders that are named here and are really looking at how can we utilize our resources together to address some of those friction points and different integration points, especially as different stakeholders are now creating their reopening plans. This work, as others have mentioned, Massachusetts has very much been a model for many other groups across the nation. And I'm going to turn it over to Danielle now to talk about how we're leveraging this work to inform conversations that are going on at the national level.
Thanks a lot, Ben. So this conversation today has been fantastic, and it's really an exhibit of why at MassCPR we're doing the work we're doing. Our public health infrastructure was not ready to handle a novel infectious pathogen with the characteristics of COVID. And so all of us are collectively really working on innovating the basic architecture of our public health infrastructure. When I use the phrase public health infrastructure, I'm not referring simply to the public components. Any public health infrastructure is a set of interfaces among public health, private sector components, and a whole lot of different systems that all need to coordinate with each other. So we can collectively think of ourselves in some sense as having lived through a period where we're trying to build the sort of interstate highway version of public health after we've previously more or less had country roads. And I think Pardis's graphic with the transition from traditional epi to genetics epi for tracing contacts and so forth is a good example of what it means to move from those fantastic, super successful country roads, but to an interstate sort of super highway system. Now, Massachusetts is at a huge advantage because of this incredible network of intellectual resources that we have here. So we really have been able to work across all different parts of the infrastructure and make that infrastructure visible. Again, all the components that we've seen today are the components of that infrastructure. We're about the only place in the country that has that capacity. And so what we are trying to do in MassCPR is not just help map out the whole system's architecture of this new innovation and infrastructure, but also to disseminate that nationally so that other states can catch up. So to the point about all the states that have not been able to implement contact tracing at the same level, that's partly because they don't actually have visibility into the structure of infrastructure that they would need, the architecture they would need in order to do that. So we are extracting, formalizing at a systems level in order to disseminate. We're also working really hard with members of Congress, Senate in particular at this point in time, to help them understand what's possible from the point of view of national infrastructure. The U.S. Conference of Mayors is deliberating a resolution today about this kind of endorsing a sort of picture of this kind of systems architecture for public health. So all the work here in Massachusetts, we believe, is the innovation center for a really dramatic increasing capacity for public health across the country. We're working to connect the work here to that broader policy conversation. And so let me pass it to Jennifer to talk about where we need help.
Sure. So from our perspective at the Mass Life Sciences Center, we are right now trying to identify the equipment that's needed to scale up the viral testing that we all have heard is an important component of mitigating the spread of this disease. So right now we have put out a public request for specific types of equipment, including the Applied Biosystem 7500, which is a qPCR machine, as well as a Kingfisher machine for RNA isolation. And so you may have already received these requests, but if you are aware of these types of devices that may be able to be repurposed in CLIA diagnosing and testing facilities, certainly make contact with me or the MassCPR folks, and we'd love to talk more with you about the importance of potentially loaning out those instruments. And at this point, I will pass it back to George and to finish up.
Great, thank you very much, Jennifer, and thanks to all of the speakers. We are seeing a number of questions surface, and some of the panelists here have already been answering them by typing but let me just take a few of the questions and I'll call on particular folks. I also invite Arlene and Bruce, our faculty leadership of the MassCPR, to help moderate as well. Ed and our questions that have come in about droplet nuclei and the effectiveness of masks and the like. So if I say, since droplet nuclei, and I think that mirrors several other questions that really ask about the effectiveness of face shields. So I might ask you to just speak a little bit more, Ed, about face shields versus masks in the protection against droplets.
Well, face shields, of course, are most effective for stopping projected droplets that would otherwise end up potentially on your face or your eyes or even mouth. And but for droplet nuclei, of course, they are going to just go around a face shield. So to the degree that there's potential for infection by the airborne route, that's one clear distinction, that a face mask, particularly a respirator, which is designed to protect a wearer, is likely to be effective, whereas a face shield would not be for droplet nuclei. They're really tiny droplets.
Thank you. There were a number of questions relating to antibody testing, and so I might ask Michael, Mina to address this. If an individual believes they've been infected by COVID but were not tested initially, what are the opportunities to receive an antibody test in Massachusetts? Perhaps Michael or David Walt or anyone else might want to weigh in on the availability of antibody tests.
Yeah, so the antibody tests, very accurate antibody tests, are becoming increasingly available. There's going to be studies that are going to be including a lot of people, thousands of people in Massachusetts. But today, people can actually go online and order antibody tests from Quest and LabCorp, for example. Some of them you might actually have to go to a facility to get your blood drawn. But you can actually order these. And I would suggest that if you're very interested in getting an antibody test, just call up your physician. Most physicians know how to get one of these tests today.
David Walt, anything to add to that, or anyone else? You're on mute, David.
This is Ben. I'd just like to say one thing on that is, in terms of funding that we were discussing, there's a difference between who pays for a medical diagnostic test and who's going to be paying for an antibody test. So it's important to know that that may not be covered by insurance. So just keep that in mind, especially as this may be more prevalent in different socioeconomic populations.
And George, the only thing I'd like to add is that as others have said, what you do with that information is still unclear. Just because you've been exposed does not necessarily mean that you're protected. And we know from results just published this week that the persistence of the antibodies is fairly transient. So just getting tested and getting the information, I think it's useful to know that you've been exposed, but it doesn't necessarily provide you with anything actionable.
That's very, very helpful. We have a question actually also a bit more detail about the various serologic tests that are available. What antibodies are being detected? IgM, IgG, IgA. Perhaps Michael or one of the other folks in diagnostics who work with these antibody tests. David, perhaps you know also which of the commercial tests are detecting which of the antibody subtypes.
Yeah, most of the commercial tests are measuring IgG and IgM, but it's turning out that IgA, because this is a mucosal disease, is an incredibly important isotype, that is class of antibodies. And as we move toward saliva testing, I think that some of the antibody tests will probably begin to use IgA in preference to IgG and IgM.
Thank you. There seems to be quite a bit of interest in this issue of the meaning of an antibody test to an individual. David mentioned that there are some issues about how to interpret it. Maybe I could just ask Bruce or Arlene to just talk a little bit about how to integrate the information and what additional data we might want to collect as a community before we can make recommendations that recovery from a prior infection does indeed suggest a degree of immunity. Bruce, you want to take that, and then perhaps Arlene?
Yeah, I think that there are, there are studies underway in healthcare workers that may help to answer that question, but I think we're a long ways away from having an answer. On the one hand, we have to see, some duration of time transpire before we can know how long these antibodies actually last. But as David Walt was saying, a paper that came out earlier this week indicates that in people that are asymptomatic, about 40% of those will become seronegative over a relatively short period of time. If you're more symptomatic, you have higher levels and the loss of antibodies is less, but we only know from a monkey study that was done actually through the MassCPR that having antibodies can protect, at least over the short term, from reinfection. And that's with a caveat. It actually didn't fully protect from reinfection. It attenuated the disease in a fairly dramatic way. So I think for now, we have to assume that antibodies are not rendering people protected from reinfection, and have people continue to wear masks and socially distance and do the hand washing.
Thank you, Bruce. Arlene, yeah, to add to that.
Yes, I would agree that we're really at an early stage of understanding the meaning of antibody and the longevity of the response. And so we know from other coronaviruses that some of the antibody responses may not be long-lived, meaning for years, but it's early days here. We know that following and understanding T-cell responses can also shed light on how to interpret the antibody responses. And at MassCPR, we also have a number of T-cell studies underway that I think will help us interpret the antibody tests.
Thank you. I mean, this is a very, very important bit of guidance here, is that we are still gathering important information about the nature of these antibody responses and the durability. And it certainly raises the importance of finding a vaccine and documenting that a vaccine can induce high enough levels of protection that we can ensure that individuals would be immune. Maybe one last question, because we're coming to the end of the time. There's a very interesting question inquiring about the interesting items on the board display behind Michael Mina, but I think we'll pass on that. Back to Ed Nardell, because you raised this issue of UV decontamination that has shown effectiveness against tuberculosis. Is this a practical and affordable solution for public schools? There are a number of questions about what public schools can do to ensure as much safety for their students.
Thanks for that question. In fact, it's the most affordable. Germicidal UV is the most affordable way to increase the equivalent air changes when I mean equivalent is destroying virus or inactivating virus.
I'm sorry. I've lost Ed, perhaps others have as well. Given that we're coming upon 9:30, let me say thank you to all of the participants. We had over 400 participants on the call. And we invite you back to the MassCPR website for more information and to stay tuned to future public briefings as well. Our goal is not only to perform the science, but also to continue to educate the public on these very important issues. Thank you very much, and stay safe and continue to wear your masks.